Okay, so today I'm going to attempt to put the most comprehensive list of drugs used for the purpose of bodybuilding ever on the internet. So I have to do a couple of disclaimers first. The first one is that I'm not a doctor, I'm a medical student. I will be a doctor in 8 months, God willing. And my advice is nowhere near as good as your own personal doctor's advice. Secondly, this is not about whether the drugs actually do what they're taken for, whether they're safe or anything like that. This is just about what they are and why they're taken. And the reason I'm doing this is to give a little bit more insight uh, as to like what is actually being done, because I think that a lot of doctors really don't know what's actually happening out there in the world in terms of bodybuilding. The other thing that I have to make sure that I say is that a lot of these drugs aren't known to the scientific field. So there is a research paper that I read before doing this that managed to find 5 different drugs. And that's nowhere near as many as I found. I think in the end I found close to 60. A lot of the information doesn't come from places necessarily where scientists would normally get their information. I tried to do that as much as possible, so I started going through databases where medical research is published, like Ovid Medline and PubMed. But if the information wasn't available on there, I went through Reddit, basically, bodybuilding forums on Reddit. And I won't get into the nitty gritty about how I managed to organize my data finding and stuff. But the point I want to make is that everything that I say in this needs to be taken with a massive grain of salt. This is not verbatim. This is not the truth. I'm probably missing loads of things. I might have got loads of things wrong. So I have to say all of that. But without any further ado, let's get started. So the way that I split up the different drugs is not based on the chemical nature of the drug or how we describe them in medicine. They're based on the the way that they're taken or the purpose for which they're taken. First major group of drugs are muscle gainers. So that's literally just for gaining muscle. That's it. The next subgroup down from that is that we're going to talk about hormones first. Testosterone has been used by the bodybuilding community since the 1930s, which is when it was first synthesized. And since then, whilst different forms of the chemical of testosterone have been used, it's still it's still the most used thing. So if you ask any bodybuilder what they're taking, the absolute bare minimum, if they're not natural, is some form of testosterone. The first couple of ones in under testosterone are DHEA, otherwise known as prasterone, or the proper name is sorry, I'm reading off a thing here because some of these names are really long. Is dihydroepiandrosterone. So basically, I think the idea with that is that it starts off. It's like a precursor to testosterone, so it gets converted into testosterone. The second lot are so synthetic anabolic steroids. So 1-androstenedione derivatives. So that includes 1-epiandrosterone and 1-testosterone. There are a couple of other drugs that also exist in this class, but I couldn't find any evidence of them being used. Then there's the testosterone prohormones. So that's things like androstenedione and 5-androstenedione. And I have to make a point with the second one. 5-androstenedione may not actually be taken directly. It was just found that it was excreted from the body, so it might just be a metabolite. And then the next one is nandrolone, or basically 19-nor prohormones. Again, another just group of prohormones. And then you have your direct anabolic androgenic steroids. So these are things like testosterone esters, the derivatives, analogs, and dihydrotestosterone derived steroids. So just a long list, basically. I think these are basically the staple. Um, and the reason why people might take one over the other is because of the way that one might interact with their body compared to other people's, or it might be because some of them are longer acting and that sort of thing. So there's testosterone enanthate, sorry, testosterone cypionate. I don't know if I'm saying these words right, by the way. Testosterone propionate, methyl testosterone, nandrolone, boldenone, trenbolone, oxandrolone, sorry, uh, stanozolol, turniball. I'm butchering these. Methasterone, otherwise known as Superdrol, Trestilone, which some people know as Ment, MENT, Drostanolone, and Mesterolone. And a couple of interesting bits on these is that Mesterolone might only be used as a post-cycle therapy rather than actually for building muscle. And there was a couple of drugs which I was kind of surprised that weren't used, but I'm sure there's a good reason why. So testosterone undecanoate. How do you say that? Testosterone undecanoate and methyl 1 testosterone. And then you have these things called designer or modified anabolic steroids. And for the most part, I think that they're mostly used by people who are maybe elite athletes rather than bodybuilders, for example, because they want to go undetected and that sort of thing. But there was one that I thought kind of came under the definition of bodybuilding use, which was metribolone or methyltrinolone. I think it's how you say that. But for that last one, I think the citations was like especially dubious. So just pinch of salt. And then you've got things called SARMs, which are basically selective androgen receptor modulators. The idea is that they selectively bind to different receptors, different testosterone receptors. Some with really strong affinity, and some basically with none. And that the idea behind that was to stop you from getting the side effects. But I think the research basically goes against that now. And I don't want to get too into it, but I think basically, in order to get the same effect as you would take from taking a testosterone injection, you need to have a massive amount of these SARMs, and then your liver has to like break down the SARMs, and basically it just knackers your liver. And I think there's also a bunch of other side effects which aren't particularly nice. There was something weird stuff going on in rats. But anyway, so these include ostarine, which is otherwise known as a Nebosarm, Ligandrol, which has the research name LGD-4033, Rad 140, S23, and YK11. There was with the S23 and YK11, it was a bit even more dubious than the other ones. So, and then finally, so those are basically all of the things which interact in some way with the androgen receptor. Now we've spoken about all of the drugs that are bind to the testosterone receptor. Let's talk a little bit about why they're used and how they're used. So some of them are oral, some of them are injections. And the idea is basically that if you increase the amount of testosterone in your body, it increases the amount of masculinity there is. And with masculinity, you've got things like excess hair growth, hair loss on your head. But one of the things amongst many is muscle growth. So people will take it in two different ways. One of the ways is in cycles. They take it in an 8 to 12 week period. They increase the amount of testosterone in their body, and then they'll take post cycle therapy once they're finished, which we'll get into later. But basically, it means that they have like really high levels of testosterone, and then they crash down for a bit, and they try to reduce that crash by taking some other medications. The other way is blast and cruise. And blast and cruise is where someone will take testosterone replacement therapy dose level of testosterone. So for a period, and then they'll take for the 8 to 12 weeks, they'll take a bigger period, a bigger dose. So they might have 5 times, 10 times the amount of testosterone for 8 to 12 weeks, and then because they don't want to deal with the side effect of suddenly stopping the testosterone, they'll just keep injecting testosterone, but at like the normal level, rather than completely switching it off. So basically, what they do is they're basically completely removing their entire natural testosterone production for that period. Okay, so the next group is growth hormone related drugs. So the first one is obviously growth hormone, and insulin like growth factor is another one. And then you've got growth hormone releasing peptides. So there's GHRP6 and hexarelin slash examorelin. Sorry, butchering names. There's growth hormone releasing hormone analogs like CJC1295 and sermorelin. But I think the one for CJC is like the evidence was really, really bad in that case. And then there's growth hormone secretagogues. So these are things like anomorelin, capromorelin, ibutamorin, ipomorelin. And there was a few other things which I thought I was surprised that they weren't included, like ghrelin and stuff like that, but they weren't used at all. And I think basically the idea about these growth hormone related drugs is that they promote collagen synthesis in tendons, leading to increased muscle strength. And then I think some people claim that it helps you put on muscle and lose fat at the same time. And I found one quotation that said the reason they thought this worked was repartitions nutrients and triggers cells to make more nutrients. But to be honest, that sounds a bit wishy-washy. I don't know if the science necessarily backs those claims that it does both of those things at the same time, but there you go. That's the reason why they take it. So the next group of medications are insulins, and I haven't listed every single different type of insulin, but basically you have long acting, medium, which are quite rare acting, and long acting. Now, there's a whole host of potential serious side effects of taking insulin, but I did say I wouldn't get into that. But basically, insulin is the hormone that takes sugar from your blood into your cells. So it can replenish glycogen stores. It can replenish basically your whole muscle with sugar, etc. And so if you're in like a carb loading phase, or like you're trying to bulk up, they'll take insulin potentially with their meals. I think most people, I don't know, this is a guess, but I'd imagine most people go for long acting just because short acting can have some really serious consequences. But don't quote me on that. Okay, so that was all of the muscle building drugs. So the next group of things is fat reduction, because obviously you have a bulk and then you have a cut. So the drugs, there's actually a really wide range of drugs that are used in the fat reduction bit. So one of them is beta agonists. So beta agonists are used for all kinds of things, mostly asthma, but bodybuilders will take either clenbuterol or sometimes salbutamol. So basically the idea about using beta agonists is that it increases the amount of lean muscle and helps you lose fat at the same time. I think clenbuterol has some agonistic effect on B3, which is involved in the fat metabolism pathway. I could be wrong with that. But basically, I think that's the idea. I think it also makes you quite shaky. So if you're moving more, your basal metabolic rate is basically increased and you're burning through more calories in a day. The next group are GLP-1 agonists. So these include at the moment semaglutide, which you might know as Ozempic, tirzepatide, which is otherwise known as Mounjaro, and retatrutide, which is one that hasn't or might have only just now actually come out of research trials. GLP-1 agonists are really interesting actually. So GLP-1s are not actually banned in the World Anti-Doping Agency's ban list of medications. So basically, semaglutide just works on GLP-1, um, and GLP-1 basically will stop you from feeling necessarily like hungry and that sort of thing. Tirzepatide works on GIP as well as GLP-1, and retatrutide works on 3 receptors. So it works on GLP-1, GIP, and glucagon. Um, yeah, and basically it just melts through fat, stops you from feeling hungry, that sort of thing. The last group are thyroid hormones and thyroid hormone pathway. And basically, the majority of them will be taking, I think, T3, and there's T4 as well, and they're thyroid hormones. And then thyroid hormones, for me, I think those are the ones which terrify me the most if someone says that they're on them, because basically thyroid hormones are um, really important hormones for keeping your like metabolic rate balanced. But by taking a load of them, it will basically increase your metabolic rate. So anything that you can think of in your body pretty much makes it happen quicker, which means you're producing more heat, burning through more water, burning through more fat, etc. Very scary, very scary. And then a weird subsection group is drugs that improve aesthetics without directly altering fat or muscle. Um, and within that class, the only one that's sort of regularly used by bodybuilders is diuretics. There's a number of different diuretics I found being used. So there's trimeterine, hydrochlorothiazide, furosemide, amiloride, and spironolactone. And basically, I think the idea with that is they make you urinate more, and you'd only do that in the last, I don't know, I'm guessing week or two leading up to the competition. And if you're urinating a lot more, then you've got less water in the subcutaneous area, which just makes you look skinnier than you are, I suppose. So finally, I found that bodybuilders are really most of the time really good at knowing that they are taking something that's potentially very detrimental to their health, and so they want to reduce the side effects um, of taking, massive amounts of hormones and stuff. The main kind of things that they want to tackle are the hormone side effects, the side effects you get from taking hormones. Um, your body has this thing called homeostasis, and so if you have too much of one thing, it will really try and reduce it. So if you have too much testosterone, it will reduce the amount of testosterone you're producing. So if you stop taking the testosterone, then you'll be left with a very low level of natural production. One of the things that they take once you've finished your cycle is they want to improve the testosterone production again. So one of the things they take is human chorionic gonadotrophin. And then another big thing that they're worried about is the estrogenic side effects, because testosterone gets turned into estrogen in the body by an enzyme called aromatase. So there's a couple of different ways of stopping that from happening. One is aromatase inhibitors. So they're things like anastrozole, letrozole, sorry, and exemestane. I don't know. They're all aromatase inhibitors. They block that enzyme. They stop testosterone turning into estrogen. Another thing is they might use is, rather than blocking the aromatase enzyme itself, they might just stop the estrogen from binding to the hormone sites, binding sites, the estrogen binding sites. So you can use selective estrogen receptor modulators. And I think these were mainly made as anti-cancer drugs for things like breast cancer. Um, but it has the effect of reducing the amount of breast tissue gained as a side effect of taking testosterone. So, uh, SERMs include clomiphene, tamoxifen, and clomiphene, raloxifene, and toremifene. And then there's a couple of other bits, hormones that can be sort of raised. Um, so one of the things is prolactin. So they might take cabergoline to inhibit the prolactin production. Prolactin, by the way, leads to lactation, so milk production, and people don't necessarily want that. Um, so I said that I'm not here to talk about side effects and all this of taking all of these drugs. Obviously, bodybuilders, if you were to take one bodybuilder off the street, they're not taking all of those drugs at the same time. They might take one or two testosterone boosters, have some aromatase inhibitors on the side in case they need them. And that might just be it. There are some who take more than others. There's a massive amount of variation between bodybuilder to bodybuilder. But I think that it's important to sort of draw attention to this because the scientific community doesn't really know what they're taking. And in a country like England or the UK, where it's legal to take these drugs, why are we not taking an interest in it? I think maybe part of it is due to the fact that it's not seen as a big enough problem. But that doesn't warrant the fact that we shouldn't, at least have some more knowledge on the area and that sort of thing. So in terms of where I found the information, actually, I was surprised. The majority of it did come from, um, normal scientific sources. However, there's like a hierarchy of evidence, and right at the top, you've got things like systematic reviews, and then you've got randomized control trials, and then you've got like observational trials and stuff. Very few of these drugs came from systematic reviews. Very few came from RCTs, basically none, I think. So those are the best forms of evidence, and very few of the drugs came from them. The majority of the drugs either came from case reports or autopsy reports. So basically, that might be a doctor has a guy that comes in, they go, he was taking this, I'm going to publish that. So it might have been that a lot of these drugs could be one-offs, and that's a big part of the reason why I was saying that you have to take a massive pinch of salt with this. Having said that, I found 59 drugs, and 40 of them came from those kind of sources. And 19 of them came from Reddit, basically. So, in conclusion, there are a lot of drugs used in bodybuilding. And I hope that this is a bit of a wake up call that it needs to be looked into a bit more. And don't use this as a shopping list. Some of these drugs are extremely scary. They're really, really not good for you. And definitely consult your doctor if you're thinking about taking them. Because even if you can't be persuaded not to, it's better to do it in a safe environment. Unfortunately, in this country, they should be willing to. They should be willing to help you do it safely. But a lot of doctors might be scared of doing that, so you might need to find a private clinic to do that. But honestly, I think it's just better to be on the safe side. And if you want me to do another video maybe on like the side effects and stuff, I can do that, if you'd like. The drugs that have the most research are the testosterone ones. So it'd be quite easy to like formulate a video with all of the information on the side effects of taking testosterone. Just let me know, and if you have any questions, let me know. I will put the citations up for all of the drugs. You'll see that a lot of them come from basically just conversations that happen on Reddit. So, I had to cover my back by saying that it's not the most accurate way of data gathering. But anyway, I hope that was useful.